Good morning, everyone. It is my pleasure to be virtually with you today to speak about the potential prediction of ARDS and death in COVID-19 patients using imaging data. First of all, I would like to thank the IHU and to thank Professor Dimunch for the invitation. As everybody knows, COVID-19 is the first pandemic to happen in the modern imaging era, and chest CT was right at the beginning, as you can see in this publication from January. The imaging modality of choice. There is no question currently, should we use chest CT or should we use X-ray? Chest CT is clearly the imaging modality to use whenever you deal with COVID-19. And all the publications in the literature has been quite consistent, and the findings of COVID-19 pneumonia at chest CT are relatively typical and associates ground glass opacities, as you can see here and here, as well as crazy paving and alveolar consolidation. These lesions are usually bilateral and goes through all lobes with a tendency to be peripheral and or subpleural. And with these typical findings in mind, when reading chest CT of a suspicion of COVID-19, the diagnostic performance are excellent compared to PCR, and in a wide French retrospective study done over almost 5,000 patients across 26 centers in France, the diagnostic performance were really good, with sensitivity and specificity over 90%. And in our department in Strasbourg, during the first wave, over a little bit more than 2,000 patients, we experience very good sensitivity and specificity, around 84 to 87%, and very good also positive and negative predictive values. And what is interesting is that these performance were relatively consistent over the first wave, either in the ascending, the peak, or the descending phase, where the prevalence of the disease varies significantly. Well, the performance of CT were consistently quite good. In our emergency department, chest CT was used right at the beginning of the pandemic as a triage tool and was really at the center of the management of COVID-19 suspicion. Patient went through a triage area first to get nasopharyngeal swabs for PCR, and then right after that directly to chest CT before being examined by the emergency physician. And this has proven to be efficient because chest CT is efficient for the positive diagnosis. It's also useful for differential diagnosis when COVID-19 is not ruled in, and it's also useful and efficient to assess disease severity. And remember the two videos that we saw before, one with very few lesions and the other with extensive lesion. Well, one patient was able to go home and the other patient went directly to ICU. So it looks like that we are able to predict the risk of poorer outcome using the imaging. And the question that we'll try to answer during this talk is, how can we do that, and what has been published saying us that we can do that. And we have 4 different topics that I would like to review with you today. The first one is the lesions extension. The second one is the abnormalities outside the lung. The third one is quickly speaking of an integrated analysis using AI. And the fourth one is the potential limitation of the technique. So first of all, and this is by far the most important part of our topic today, is the lesion extensions. On the European Society of Radiology guideline for COVID-19 chest CT, it is recommended to use a visual scale to evaluate the extension of the severity of the lesions compared to the whole lung parenchyma. And this has proven to be extremely useful because we published on a little over 500 patients in Strasbourg that for patients below 25%, the risk of a poorer outcome, either ICU admission or death, was 23%, whereas for patients above 50%, this risk was 70%. So there is a gradation and an increased risk with the extension of the lesion, and we can confidently say that a threshold at 50%, so below or above, is really useful to identify patients at very high risk of poor outcome. So using this visual scale has many advantages. First, it's very simple. You do it with the regular chest CT images. It's extremely fast, and as we saw, it's efficient. Problem is you need a little bit of experience to be able to differentiate between the different range of extension of disease, and there is a strong questioning about the reproducibility of this visual simple analysis. And let's look at this complicated example: patient with high clinical suspicion of COVID-19 infection. We can see here in the upper right lobe extensive alveolar consolidation that goes on both sides and on both lobes of the lungs. And the question here, are we below or above 50%? And really it needs you to get some training to be confident in saying this is above or this is below 50%. In this case, it was below 50%. So taking this limitation into account, there has been development of different visual score system, which consist of a semi-quantitative evaluation. So here are, for example, 3 different publications about that. And here are how the authors proceeds to evaluate the extensions of the lesion with a semi-quantitative manner. And while we can definitely say that it's extremely cumbersome and it's absolutely not homogenized between the publications. So the visual scoring, the only advantage in my opinion, it's that you can publish things with that. But apart from that, this is complex, this is not standardized, and there is no proof that you get better result than the very simple and very direct visual assessment. So I would forget that. Third methodology to do an evaluation of the lesion extension is a quantitative evaluation with segmentation. And this is based on the type of software that we use to evaluate and quantify COPD. So how is it working? First, you segment the lung. Then on the lung, you apply a threshold to separate the normal lung for the pathological lung. And then you compute the volume of the lesion and you divide it by the total volume of the lungs to get an estimation of the lesion. So here is an example of how it is working. First, you segment the lung, then you apply a threshold to take into account only the consolidation of the ground glass opacities that represents the COVID-19 pneumonia. And once you get it, you compute the volume of the red and you compared it to the volume of the total lung, here the blue and the green. There are a lot of caveats. So for example, when you have extensive and severe alveolar consolidation, then the automatic segmentation of the lung is extremely difficult. Also, the problem is, for example, in this case where you have very small and very limited lesion in the right lower lobe, subpleural. When you do the lung segmentation, it's very easy, but then when you apply the threshold, the abnormality is so low and so limited that the threshold will take into account a whole variety of things that should not be taken into account, like the vessels, the bronchi, the fissure, which means that, of course, here in this case, the quantification will be over and overestimated. So this approach using segmentation is relatively simple, it's relatively fast, and possibly more reproducible than the visual assessment. The problem is that there is no proof that there are added value or clinical added value over the simple visual analysis. So fourth methodology to do the quantification of the lesion extension is to use a quantitative method, but with manual supervision. This is what is done here at the EHU in the visible patient team, where they have automatic processing, which is supervised by a technologist to make sure that the segmentation of the lung is efficient and that the thresholds applied are really corresponding to disease. So what are the advantages of this technique? It's very easy because you just have as a clinician to send the data and then you get back the answer. You do not do anything. It's highly reproducible because there is supervision of the results, and it has proven to be efficient in an initial feasibility study. Problem is the workflow. It's very cumbersome because you cannot do right at the workstation. You have to export the data, then wait for the results. So it takes a few hours or days. And the second problem is the cost. So this is probably efficient, but I do not think that this is usable in a routine setting. Last possibility is a quantitative evaluation with deep learning. It's classical usage of convolutional neural networks to segment disease. So you just train a CNN to recognize the lung parenchymal lesions. It has been done by multiple industries, and softwares are already sold, and it's very easy because it's one click. It's quite reproducible and you get immediate results. Problem is the cost of this software. So if we go through the 5 possibilities to evaluate the lesions extensions, I think that the clear winner, and by far, is the visual scale, because it's very simple, it's direct, and it has proven to be efficient in multiple publications. I would say that the second runner would be deep learning, which works really well, but is very easy and quite fast as well, but needs to have the proper software and has cost associated with that. Okay, so that was the major portion of our talk. It was how to evaluate the lesions extension and the relationship with the prognosis. So now let's try to look outside the lung to see if using imaging data we have abnormalities that are associated with the prognosis. And indeed there are. And the first one is an abnormality that we reported in our department is the adrenal gland infarction. And we did an analysis of over 200 patients with extensive and severe pneumonia. And 23% of those patients had sign at chest CT of acute adrenal gland infarction. And the presence of this was associated with a poorer outcome. So here are some examples. You can see here this is simply the upper part of the abdomen that is always in the field of view of the chest CT acquisition. You can see that the adrenals are enlarged and with fat stranding around it. So these are indirect signs of adrenal gland infarctions, and this, when present, is a marker of poor prognosis. And there has been another lesion that is really easy to see at chest CT and is associated with a poorer outcome. It's coronary artery calcifications, and this study has been done in Paris over 200 patients with just stating the presence, yes, or the absence of coronary artery calcifications on chest CT in COVID-19 patients. And if you have calcium present over the coronary arteries, then it means that there is a higher risk for ventilation and death, and this has proven to be statistically significant. So this is maybe an additional step to the lesions extension evaluation, but if you have either adrenal gland infarction or coronary artery calcification and chest CT or a combination of both, then maybe that would hint towards a possible poorer prognosis. So this is what has been proven yet with just a visual analysis of chest CT. And there are more and more approach and studies to use an integrated analysis with artificial intelligence. And the studies are based on the use of not only chest CT, so imaging of course, but also clinical and biological data. And the methodology is very easy. You use a training set to train a convolutional neural network to predict the outcome. So the input would be images, would be clinical data, would be biological data. The output would be ICU and or death, and you will feed the network with 500, 1,000 or maybe 2,000 patients, and then the generator will train and you will test it over a testing population. So it means that, of course, as for any artificial intelligence application, large data sets are needed, and this is quite difficult to obtain. And I just want to share with you two examples from France. This one was done over a little less than 700 patients with more than 300,000 CT slices and incorporation of demographics, clinical and biological data. And you see that the balanced accuracy for staging and for distinguishing severe versus non-severe COVID-19 is about 0.8, which is actually quite good. Here is another example from France, also from Paris, in just a little over 1,000 patients. So you see more than 500,000 CT slices and incorporation of 58 variables, demographics, clinical variables, biology, and all that will give you an area under the curve to predict death or ICU admission of about 0.8, 0.86, which is actually quite good. So are there limitations to the approach of using imaging data to predict the outcome? Yes, because not everything lies within the image. And this is a study that we did in our department, looking at all the initial chest CT of COVID-19 patients. And we isolate the patient that had strictly normal, so absolutely normal chest CT at the ED admission, and we compared it with a matched group of patients with abnormalities at their initial chest CT. So of course, if you have lesions on chest CT versus patients with absolutely normal chest CT, the control group with chest CT lesions had a poorer prognosis, and by far, and this was statistically significant. But what is quite interesting is that in the study group with completely and absolutely normal chest CT, then yet there were 3 patients, so about 5% of the cohort, that experienced death and/or ICU admission, which means that if you have completely normal initial chest CT, it does not necessarily mean that you are absolutely protected and not at risk of a poor outcome. So this is extremely interesting. We do not have yet any explanations for that. Of course, if you are early in the course of the disease, then you have more chance to have a normal or a subnormal chest CT. But in this study, we had patients that were about 7 to 10 days from onset of symptoms, and yet their chest CT was completely normal. So there are still some stuff that are not completely understood here. We arrive at the end of this talk, and to conclude, I would like to stress out again that chest CT is the imaging modality of choice for COVID-19. Of course, to do the positive diagnosis, which has been proven extremely useful in the first wave when RT-PCR was difficult to obtain. This is less useful now with extensive testing available, but still this is a real advantage of chest CT. And as we saw, chest CT is also extremely useful for severity assessment, and it has proven to be correlated with the outcome. And as we saw, the major, by far, the major predictor of poor outcome on chest CT is the lesion's extension. And this is something that should be reported for every chest CT. In my opinion, and this is really by far compared to all other techniques that are available and that we saw together today, the visual evaluation with the European Society of Radiology scale is sufficient. It should be done for every chest CT of COVID-19 patient. So in my opinion, this is something which is mandatory, and you should not need to go deeper or more precise than this very simple visual evaluation. So to conclude, I would say that AI might help, this is absolutely not certain. And to be a little bit on the jokey side, not know, because the AI software are not available or validated yet. So I hope we won't experience a third or fourth wave where AI could help, but currently we still rely only on the visual evaluation of our examinations. So with that, I would like to thank you for your attention, and we have the open questions afterwards. Thank you very much.